Now moving on to my evaluation criteria of my images of the knee and technique for the projections that I just demonstrated as well. So starting off the AP knee here image, we're just looking out for evidence of proper collimation, making sure that the knee was fully extended, just depending on the patient's condition as well. And I'm mainly looking that the entire knee is without rotation, and also can be found using the femoral condyles being symmetric and the eminence being centered in the image right here. And then we also want a slightly superimposition of the fibular head in the tibia, which is quite normal. And then also looking for the patella being completely superimposed on the femur, which can be found right over here. And also looking out for open femorotibial joint space, with the inner spaces being equal with both sides of the knee, and that's primarily the reason why we use a tube angle. And lastly, but not least, looking out for soft tissue and bony trabecular detail as well. Ballpark range for an AP knee would be 85/5, just primarily because we're using the table bucky for the moving on to our next projection here, an AP oblique of the knee with medial rotation. And for the evaluation criteria for this image, we're just making sure we have proper collimation again, tibia and fibula separated at their proximal articulation, which is right here. And then we're looking out for the posterior tibia, and then lateral condyles of the femur and tibia, and making sure we have both tibial plateaus, and making sure the margin of the patella is projecting slightly beyond the medial side of the femoral condyle. So make sure that patella is pointing medially, and looking for an open knee joint once again. And then just making sure we have soft tissue and bony trabecular detail. And ballpark range for this projection would stay the same as an AP knee, just because we're using table bucky. So 85/5 would be appropriate. And moving on to the AP oblique projection with lateral rotation of the knee. We're just looking out for evidence of proper collimation once again. Medial, femoral, and tibial condyles. Tibial plateaus are present. Fibula superimposed over lateral half of the tibia, which is the main reason for this projection. So we're just making sure we have superimposition. And then margin of the patella projectly slightly beyond the edge of the lateral femoral condyle. So we want patella towards the lateral side here. And once again, open knee joint, soft tissue, and bony trabecular detail. And ballpark range for this image would stay the same as the other knee images that I've gone over, 85/5, reasoning being the use of a table bucky. Moving on to the projections of the intercondylar fossa. This is an AP axial projection of the intercondylar fossa, also known as the Beclaire method. And our main goal here is to have the open intercondylar fossa, which can be found right here. And then also looking out for posterior inferior surface of the femoral condyles, intercondylar eminence and knee joint space. So making sure this is nice and open knee joint, and we have room in the eminences as well. So also no superimposition of the fossa by the apex of the patella, and we can see we're nice and clear here. And also making sure no rotation, which can be demonstrated by a slight tibiofibular overlap, once again, just like our AP knee. And also want to be on the lookout for soft tissue and bony trabecular detail. And since this projection was performed tabletop, our technique would be shifting to 70/5 ballpark range. And last but not least, our final image is a tangential projection of the patella, also known as the Sedigas method. And the goal here is just to make sure we have proper collimation. We're just looking out for the patella, so it's okay to collimate in slightly. And we want the patella in profile, and it is nice and visible here. And also goal is to have the femoral condyles and intercondylar sacculus. And we want to open patellofemoral articulation, which can be found right over here. And then just looking out for soft tissue and bony trabecular detail as well. And since this projection was also done tabletop, We'll be shifting our technique to 70 at 4. And this concludes my final portion of my knee trigger.